today's charge was to talk mostly, I forgot the musculoskeletal in the title here. We're going to talk about Raynaud's and musculoskeletal involvement. And again, I think how many people in here are, because I know sometimes there's spouses, there's people affected by the disease. How many people have scleroderma in the room that are here? Okay. Spouses or loved ones? All right. Chuck, I didn't see you raise your hand, man. Yeah. All right. Yeah, you're a loved one. Yeah. So yeah. All right. So we're going to go through, a little bit about. You guys know the symptoms, so I'm not going to go through the symptomatology, but I'll kind of go through how we think about approaching it, and then I'd really like to open things up and allow you guys to ask questions as well. So Raynaud's is really universal in scleroderma. So enough so that if somebody has a clinical history in their chart, and we've never met them before of scleroderma, and they say, I don't really have this Raynaud's thing that you're talking about, it really raises some flags about whether they don't have maybe a skin thickening mimic, because almost everybody with Raynaud's or with scleroderma will have some level of Raynaud's, and that could range from kind of painful episodes of blanching, and maybe for some folks it's relatively mild to moderate and more of a nuisance. And then it can, in some folks, there's a picture on the bottom here where you can see sores develop at the ends of the fingers, and so we'll call those either digital pitting or digital ulcers if they're open. And in some folks, it can even lead to loss of fingers, which is kind of the most severe manifestations. So one thing to take home from this is that it's a spectrum. So I'm sure if you guys are involved in patient support groups, you've seen that. You've seen some people who say, well, that's not my biggest problem with scleroderma. I have other things that I want to focus on. And other people, this is the main thing that they'd like to have focused on. So part of our job as docs is figuring that out. And when we're talking to somebody and saying, like, what should we prioritize, it's important to kind of make sure the doc and the patient are on the same page. So there's a couple things that we can do with non-drugs. So we don't need medications. And certainly for those people who say it's mostly a nuisance, this is kind of the stuff that we focus on. So some of the stuff is obvious. We don't want to be exposed to cold excessively. And what does that mean? It means keeping your entire body warm. So not just your hands and feet are obviously important, but if your core body temperature is cold, then your hands and your feet are going to pay for it as well. Stress avoidance is something that we talk about. It's tough, right? I got 3 kids, and if someone tells me not to be stressed, I almost get more stressed when they tell me that. I'm like, I got 3 little ones. But I think we all have stress in our lives, and as much as we can reduce that, because realize that when we're stressed, we have kind of our fight or flight system, right? So that's norepinephrine and epinephrine. That causes clamping down on blood vessels, which leads to poor blood flow to your digits. And so these are things that we kind of talk about. Things that I kind of mention to patients on a practical sense is that hand warmers are great things to have. And so I tell people to keep some of those chemical hand warmers that you might see where you can kind of, you kind of break it and then you can put it in a pair of gloves. I tell folks to keep that inside their glove box in their car, because heaven forbid you had car problems in the middle of January or February and broke down. It's nice to have some kind of emergency backup available. I've seen some folks that have battery-powered ones. I've had a couple of patients who actually have went to Cabela's, and they have these gloves that have like electric heaters in them. And so patients are kind of more innovative than I think I am, and so they've found good solutions to some of these problems. In terms of biofeedback, this is something that's looked at for primary Raynaud's. So we often talk about primary versus secondary. Primary Raynaud's is somebody who has the blood flow problems but doesn't have scleroderma or another underlying problem. They just have the Raynaud's. And in that situation, biofeedback, which is basically, it's not counseling, it's basically getting a patient to understand how stress and their mindset feeds into worsening of their symptoms, that you can break that cycle. Biofeedback for secondary Raynaud's hasn't shown that much promise. And that's probably because in scleroderma, the way we describe it to our residents is that it's a 2-hit problem. So in primary Raynaud's, it's a clamping down of the blood vessel. So either in response to stress or cold, you get constriction of the blood vessel, decreased blood flow to the hand, and that's when it can turn white. In scleroderma, you have that same process, but you also have a secondary process, and that's usually you get thickening of the blood vessel. So even when you're not clamping down or constricting, most folks with scleroderma, if we looked at their blood vessel, it can be thickened, and so you already have a little bit of low blood flow. It's that, for that reason, in primary Raynaud's, we never see sores at the end of the fingertips. If we see sores at the end of the fingertips, there has to be something else going on than just the vasoconstriction component. But because scleroderma folks usually have both of those issues, you can't use biofeedback to get rid of the thickening of the blood vessel. So I'm not saying that there's not any role for it, but the data is not that great. And certainly I think those things cost money. I don't usually recommend something that has a lot of costs that's not going to have benefit. Smoking cessation is important. So, why is that? Well, smoking can contribute to poor blood flow in general too. And so the way I just phrase it to most folks is that we don't want a second reason for your fingers not to get blood flow. And so there's health benefits of stopping smoking anyway, but this would be, one that we would recommend. The last two, they're pretty invasive. So usually when you see non-pharmacological therapy, you're thinking of kind of, things that we can do that are kind of minimalist. So these would obviously be more aggressive, and I usually would not refer somebody for surgery before we've tried medicine. So in terms of order of trying things, everything above smoking cessation are things that we would do first, and then we would offer usually medical therapy. But there are procedures that could be done. So Botox injections, so not for wrinkles, but for actually kind of loosening the hold of that vasoconstriction and improving blood flow, has been looked at. There's conflicting data, though. There was just a study that came out, I think, maybe in last month's Arthritis and Rheumatology that did a randomized study that showed that there wasn't any kind of large benefit. And so this is something that we had previously referred some patients for. The hand surgeons are the ones that usually carried it out for us. What does it mean by that? So I should explain that. So they basically would inject Botox into the base of the finger. So you have digital arteries that flow from, obviously, larger blood vessels in the forearm. They kind of come down into a blood vessel and then feed off into the fingers. And by injecting Botox around the base of the fingers, especially if you had one or two, primarily affected fingers that were the worst, then that could improve blood flow. Again, there's some conflicting data, and so I think I'm going to be waiting for some additional trials to come back. I don't think it's something that I've totally ruled out trying, but I think there's at least some evidence now that it might not be as efficacious as we had initially hoped. That study that I mentioned that was negative, it only included, I think, something like 40 patients, and so I don't think it's a definitive answer, but it was interesting to see. And then the last thing would be, in addition to an injection, is that when they injected the finger with Botox, that's to kind of stun the nervous system input to the blood vessels, but they can also kind of strip that nervous system input off of the blood vessels, and that's called a digital sympathectomy. So it's the sympathetic nervous system that tells the blood vessel to constrict, and so they can actually make an incision into the finger, a surgeon can, and this is an actual surgery rather than a procedure, and they can strip off the nervous system input to the blood vessel. And so that's something that can be done. It's fairly aggressive, and it's not 100%. A lot of folks will get improved blood flow and warmth in their hand, but there are reports of kind of a recurrence of symptoms, and whether that's from reinnervation or other mechanisms isn't entirely known, but it's not 100% in terms of long-term longevity. And so, again, we would try, on the next slide we'll go through medical therapy, but we would always try that first before a surgical intervention. So what about pharmacologic therapy? So I like to, I'm kind of a simplist, and so I like to think of things in kind of categories, and so we usually lump people into either vasodilating agents or antiplatelet therapy. Those are the two main arms that people have looked at in terms of therapies. There's another group that I'll go through that kind of don't fit nicely into this box on the next slide. In terms of vasodilating agents, so again, these are ones that would relax the muscle that constricts on a blood vessel, improve blood flow. Calcium channel blockers, things like amlodipine, which is Norvasc, or nifedipine, those would be kind of our gold standards of therapy. Why are they gold standards? They have randomized trial data. They tend to be effective in a lot of folks, and they're affordable. A lot of times you can get most of those drugs on a $4 plan at most pharmacies. So this is always something that we would try first if a person's symptoms were more than a nuisance, and if something that they wanted a medication. They're not risk-free, obviously, so the biggest things with calcium channel blockers are that they can sometimes cause swelling in the lower part of the legs, and sometimes patients can get headaches with them as well. But generally, they're pretty safe otherwise. When we had slides before, I think in the research section, we were talking about cyclophosphamide or mycophenolate. In kind of comparison, calcium channel blockers are much, much safer than almost any immune suppression that we can talk about. So for the most part, if someone wants to try it, I think that's a reasonable step. Everything below it kind of has a little bit less data, but there is some evidence of support. So these are things that can actually be added to calcium channel blocker if that therapy fails. So there's alpha blocker, which is another blood pressure medicine. Topical nitroglycerin. I would use this mostly if someone was improved by our initial steps of therapy, but then they still had maybe 1 or 2 digits that were kind of problem child digits. And the reason for that is you really don't want to slap nitroglycerin on like 10 of your fingers, but it can be helpful for like 1 or 2, and especially if you're kind of sick of swallowing so many pills. One nice thing about this is it's a topical medicine. So it's usually used twice. Some people will use it 3 times a day. And the important thing is if you're on this and no one has told you this before, don't put it in over or on an ulcer. That can be very, very uncomfortable. So most of the time we're rubbing it into the base of the finger, maybe up to that first knuckle in your finger, but don't put it to the end where you might have sores, because that can be pretty uncomfortable. And then, yes? Yeah, so nitroglycerin is a vasodilator as well. So it dilates the blood vessels and improves flow. So it's the same stuff. I mean, it's the exact same stuff that someone would use potentially if they had chest pain from poor blood flow to their heart. So people have probably heard of nitro paste or nitro patches. And so some people that have heart disease will use nitroglycerin type of medications. The other caveat to this is that you can't use nitroglycerin in combination with certain medicines. So if you're on a powerful dilator, like this first one I have listed under A, this big long phosphodiesterase inhibitors, so that's sildenafil or Viagra. You can't use Viagra and nitroglycerin at the same time. It can drop your blood pressure too low and can be dangerous. So we don't usually keep people on both of those medications concurrently. Yeah, and again, if anyone has questions as we go, thank you for asking, because it's a lot easier to do it as we're going through it. In the other slide on the bottom, that's mostly pulmonary hypertension meds. So the first group, again, is a medication such as Viagra. So for pulmonary hypertension, it's called sildenafil, or it's called Revatio. And then another group are endothelin antagonists. Some examples of that would be a medication called Bosentan. And then the last one is our prostacyclin agonist or analogs. All those medications, all of those 3 groupings are FDA approved for pulmonary hypertension. They're not FDA approved for Raynaud's or with Scleroderma. So I would say that sometimes we're effective if we failed other things and we want to try one of these medications. I would say that sometimes we're effective at getting them approved, but it can be hard with insurance approval because they're not FDA approved for that indication. So if someone has pulmonary hypertension and Raynaud's, easier to get these medications. If they have just Raynaud's, it might be a little bit more difficult. In terms of order of what I use personally, I probably use sildenafil a little bit more commonly if I'm down into this group, so if I've failed initial therapy. The reason for that is that that's become generic recently. It's a little bit easier for us to assure that we're going to get approval for it, and it's a little bit easier to manage. The second group of medications, the endothelin antagonists, can have liver function problems, and so you got to monitor that much more closely. So it's, in my mind at least, it's another kind of added barrier in terms of monitoring. And then the last group, prostacyclin analogs, we have used this before. It's an IV infusion. So we typically, I would say probably it's only about twice a year that we use this. This is for someone who has really severe disease and almost is progressing to the point of critical ischemia. And so at least here at our institution, this isn't offered as an outpatient. It's usually a patient that's admitted to the hospital and would get IV therapy in the hospital to try to open up a artery that we're concerned if we don't do something differently that we might lose part of the finger. Antiplatelet agents, I would say aspirin is our go-by. So unless someone has kind of stomach issues, gastritis, or a bleeding ulcer, a lot of folks that we have with difficult to control Raynaud's, we would also put on a baby aspirin. And then I have other antiplatelet agents kind of listed here as well. I think I have one more slide on treatment, but yeah, maybe some questions.
A question, are these drugs, do you use them mostly as preventative to keep ulcers from happening, or do they actually treat the ulcers?
Yeah, so that's a great question. So everyone hear that question is like, do we use it as a preventative strategy, or are they used once someone's established ulcers to treat? So in terms of prevention, I don't think many of us are using it like if somebody has mild symptoms and they're not bothered by it. I've not seen a study that says if we start some of these medications that we might prevent them from worsening over time. But if someone has bad Raynaud's without ulcers, we sometimes worry that that's the next step. And so yes, I think if someone has symptomatic disease that they feel like they're doing cold avoidance, keeping their hands warm, and they feel like it's impacting their quality of life, then we're going to start one of these medicines, whether they have ulcers or whether they don't. Because I think the bottom line is if your quality of life is poor because of this symptom, then it deserves treatment. And then it's a discussion of risk-benefit. A lot of folks, unfortunately, with scleroderma sometimes can have lowish blood pressures to start with, so that makes some of these vasodilating agents tough, right? Like, how many people are on one of these medicines right now? Amlodipine or diltiazem, those would be count. So, and how many people had problems because of lightheadedness or low blood pressure? Yeah, so there's some, there's at least 4 hands that went up out of the maybe 6 or 7 that had it. So that's kind of a rate-limiting step. But I think we have to balance that, like how much are the symptoms helped versus a risk. In terms of ulcer kind of healing, some of the studies have looked at like that endpoint of saying like someone has existing ulcers, start the medicine, how much improvement do they get? So Bosentan, is an endothelin antagonist. Its trial, it failed to heal existing ulcers, but it did prevent formation of new ulcers. Unfortunately, that's why it didn't get FDA approval. The study was designed to answer the question of will it heal existing ulcers. Compared to placebo, the ulcer healing rate didn't go down, but people tended to not get as many of them. So I think there is some evidence that maybe vasodilating the blood vessels will help prevent some of those from forming. And I think if someone has bad symptoms, then I think it's the right thing to do to intervene, and then we hope to prevent more serious complications. Yeah. Yep.
So I don't even know for sure, but I think what I have is I have calcium deposits that form underneath my tips in my finger.
Mm-hmm.
Eventually, if I don't expel the calcium,
Yep.
that forms an ulcer type of effect. So is that related to what you're talking about?
That's a little.
Is that a different symptom?
Yeah, that's a different process. So the question was that you have calcium deposits that sometimes can ulcerate over it, and that's a different process in terms of the calcium can be locally irritating to the skin, and it can cause breakdown. But increasing blood flow to the hand has not clearly been shown to decrease calcium deposits. Calcinosis is a very, I'm not touching upon it formally in what I have left in the talk. It's fine that you asked though. But it's a very difficult problem in scleroderma because we don't have great medical therapies. People have looked at calcium channel blockers, and I think the data is pretty equivocal about whether that helps. People have looked at bone health medications. So if anyone's heard of bisphosphonates, things like Fosamax or Beniva, those are used for osteoporosis. People have looked at whether using those medications can help with calcinosis. Probably the best data we have is actually from the pediatric literature. There's another condition called dermatomyositis where the kids can often get calcium deposits. And I'm aware of literature from in the peds world that they've used some of these bone medications because those medications can drive calcium into bone. And the thought is that you have less calcium to kind of form in these calcinosis sites. But I find it very challenging. If it's getting to the point where it's leading to ulcerations, then sometimes, especially if they're on your fingers, we'll get the hand surgeons and a wound therapist involved, because sometimes it does have to be, if it doesn't locally expel by itself, if it's secondarily infected, they'll have to do debridement in that area. You have to force it. You don't dig in your hand, though, do you? Yeah. Sure. Yeah. During that inflammatory response, sometimes, because calcium is, the best way to think about it is that your body's trying to reject it, right? It doesn't understand why there's calcium in that area. So sometimes if it's really red and inflamed at that time, people have looked at using like a brief short term of immune suppression to help with the inflammatory response. So prednisone's been looked at. Another medicine called colchicine has been looked at as well. So sometimes we can do those, but if it's short-lived, it eventually kind of comes out. There's risk with all those medications as well. So that's kind of a discussion with your individual doc, which I think is fish. So yeah. And again, feel free to kind of ask questions as we go. So again, vasodilators, antiplatelet therapy, and then there's kind of like an other class. And so these other medications that have been looked at don't kind of fit great into those arms. One is fluoxetine. So that's actually a depression medication. So it's in a category called a SSRI. There's been a randomized study that shows that that's effective. It's not 100, in that study, it's not sure if that's because of this stress epinephrine clamping down cycle, but there's also off-target effects of SSRIs, and so there's some of the molecules that it inhibits might be involved in vasoconstriction as well. I list these because if someone comes into me is already on a calcium channel blocker and their blood pressure is 100 or even lower, like in the 90s, it's really hard for me to imagine that they're going to tolerate being on more medication to drop their blood pressure further. And so this kind of arm here of a depression medication, fluoxetine, or cholesterol medications, they don't tend to affect your blood pressure. So they're options to consider in somebody that's limited by lightheadedness, low blood pressure. Cholesterol medications, again, it's small randomized studies looking mostly at folks with ulcers and healing of ulcers over time. And so sometimes we'll use cholesterol medication even if someone's cholesterol is not necessarily elevated. So again, that's because cholesterol has vascular health benefits that extend beyond just cholesterol lowering. So you don't have to have high cholesterol. Insurance may disagree with me, but if someone has normal cholesterol, we would still sometimes consider using statins in a difficult patient case. So this is just some summary information. So again, it's the initial complaint in 70% of folks with scleroderma, but it's nearly 100% in scleroderma folks overall. The one caveat to that is that when in folks with diffuse versus limited, has everybody in this room heard that distinction, limited scleroderma versus diffuse scleroderma? Okay, I'm seeing nodding of understanding. So in the diffuse folks with scleroderma, when they initially present, there can be a subset that present very, very rapidly and have kind of a very rapid onset of disease. And that's the one group that may not have Raynaud's for years before they are diagnosed with scleroderma. And really it's just because the symptoms progress so rapidly that these other things that I have listed here may occur before Raynaud's happens. Otherwise, in most cases, Raynaud's predates all other symptoms of scleroderma, typically on an order of years before it's identified. Musculoskeletal involvement. So I have things listed here. I didn't go. That was part of what was asked to talk about, but it's tough to talk about it because there's not a lot of data in what to do and what to treat folks with musculoskeletal involvement. I think that I broke down potential sources of musculoskeletal pain into joint pains, joint swelling, pain from flexion contractures, and tendon friction rubs. Tendon friction rubs don't tend to be painful, but they're an important thing for docs to kind of identify because that symptom it can be associated with the development of scleroderma renal crisis. So it's something that we're kind of looking for from a physician standpoint. I think one of the hardest things, I should have had a picture here, but in that last patient that we described, so the person who has kind of new onset, rapid onset scleroderma, they can develop what we call puffy fingers, and I think I had that on the slide before. Trying to tease out, that response is really a reaction of your hand to decreased blood flow. So your hand kind of gets edematous or swollen in response to that. Trying to tease out that presentation versus underlying arthritis can be very, very difficult. And so I think, the challenge for both patients and for physicians is when someone comes in with scleroderma and hand pain, our job is to figure out, is that because of poor blood flow? Is it because they have an underlying arthritis? Is it because the swelling in the hand is pushing on maybe the nerve and they're actually describing carpal tunnel? Because you can understand that identifying the etiology, the treatment is different. If it's a swollen hand that's painful because of blood flow, that doesn't respond to immune suppression. If it's inflammatory arthritis, then maybe using medications that they might use in rheumatoid arthritis may be helpful, but I think that's the minority. Most of the time, when I see folks with scleroderma, most of the time when they have hand pain, it's from blood flow issues or it's from the flexion contractures that can develop. And I think it's important to highlight that those, we have so many commercials on TV now telling us that we should be taking Enbrel or Humira or another medication to help with your arthritis symptoms. But those manifestations I just described, a flexion tendon contracture or pain from low blood flow, they won't be helped by Humira or Enbrel because it's not the immune system attacking the joints, it's pain from blood flow limitations. Does that make sense? There are a subset of folks that can get an inflammatory arthritis, but it's probably less than 10% of the folks with scleroderma that present with hand pain that actually have an inflammatory arthritis. And in that circumstance, so if we examine them and we're like, yeah, we think this is more arthritis, then sometimes medications that we use for rheumatoid could be used. So methotrexate is sometimes used for skin thickening, but it can also be used for joint inflammation and RA. And then sometimes I do have a couple of people on an anti-TNF inhibitor, primarily for joint involvement, so things like adalimumab or Humira. But again, that's a very small subset of what we see. A couple things about flexion contractures. This is the reason why if someone's newly diagnosed, we really want to get that individual into occupational therapy. So flexion contractures develop because when you develop skin thickening across the joint, it can pull the finger or the other joint areas into a contracture. So have you guys all heard that term of a flexion contracture? Meaning a lot of folks with scleroderma can have trouble extending their fingers out completely, right? And so that makes it very difficult to navigate things in terms of using utensils, using a pencil, developing kind of tight grip strength. And that happens because the skin thickening can cause the tendons to be foreshortened. The reason why it's vitally important to get in to see an occupational therapist just to help with range of motion is that even if we reverse or improve some of the skin thickening, once a tendon has shortened, there's not very many medications to my knowledge at all that are going to allow that tendon to re-lengthen. Does that make sense? So if someone has a tendon flexion contracture, it's hard to reverse that with any kind of means. And so we want to be able to maximize range of motion as early as we can in the process before that kind of sets up shop. I've anecdotally had a couple of patients who've had stem cell transplants who feel that they've gained some improvement in their flexion contractures, but I've not seen a study that actually verified that kind of in a systematic way. And so again, occupational therapy, which is kind of like a physical therapist for the hands, is somebody that we try to get folks into right away. Do you guys have questions about this at all? About some of the hand pain things? So again, if we think it's a vascular source, then we would want to identify and treat according to the other slide. Yes?
Is there surgery available for something like that?
For a flexion contracture, yeah. So there's not per se. So if you look online and you see pictures of something, there's a condition called Dupuytren's, which is another. It's not arthritic condition, but it's another hand condition that can kind of pull somebody's hand into kind of like a claw shape. And in that situation, that there's like a piece of tissue or on the palm of people's hands. And Dupuytren's is almost like there's a napkin on the, that piece of tissue can be described like a napkin, and it's like it got bunched up and it pulls the hand down. in that condition, they can release that piece of tissue, and it can improve mobility. But the problem with tendon flexion contractures is they can't cut your tendon, right? I mean, if they cut a tendon, then you have no functional tendon anymore, and you can't flex your finger. Same thing, they can do they can do collagen degrading enzyme injections for Dupuytren's, but if you did that in scleroderma and injected a tendon, it would rupture, and then that would be a non-functional tendon. So there's not really a great surgical improvement approach to that, unfortunately. Yeah.
And then, I mean, I also noticed that in my own physical body, I have definitely vascular issues. Because I'm developing lots of light vascular veins and stuff like that. So is that related?
So almost like when you say vein, like almost, if you don't mind me asking, more like varicose veins and those sort of things? That's a good question that I'm not 100% sure about. People with bad Raynaud's there's definitely association between that vascular problem, Raynaud's, and other vascular problems like pulmonary hypertension. And then there's some data, there's another blood vessel problem where you can get too prominent of blood vessels in the stomach that can bleed. Whether there's an association with varicosities, I'm not 100% sure on that, actually. So let me get back to you on that. All right. So in terms of this, the talk was designed mainly for vascular issues, so Raynaud's and musculoskeletal, but I think I was going to touch a bit, just because we were talking about skin thickening leading to contractures, I was going to touch a little bit about skin involvement and kind of the approach that we use here. And so I've listed here the kind of 4 medications that I think we more commonly use for skin involvement. Prednisone is controversial because not many of us would be excited to use more than 10 milligrams. And the reason for that is that there can be a risk in higher dose prednisone use, so above 15 milligrams, of precipitating something called scleroderma renal crisis. And so, but will we sometimes use low-dose prednisone? We sometimes do, because I'm sure when you guys first were diagnosed, how many people had kind of like intense itching as an initial manifestation of one of their problems? So only 2, but it's a very difficult thing to kind of treat early on. And there's some evidence that prednisone, through kind of decreasing a type of cell called mast cell, it releases histamine and it can make people itch, that prednisone might have some benefit in that area. So sometimes 5 to 10 milligrams to help early on with symptomatic control is something reasonable. In terms of long-term management, I think methotrexate and mycophenolate, which is Cellcept, are kind of our 2 standbys. They're oral medications. They're easier for us to give. If someone has existing interstitial lung disease, we'll sometimes be a little bit reluctant, and we may not use methotrexate altogether. And that's because methotrexate can exacerbate or have a higher risk of pulmonary side effects in folks with existing interstitial lung disease. And so again, that sometimes will help us if we see someone new. We'll want to screen with pulmonary tests to see if they have either pulmonary hypertension or interstitial lung disease. And if they have one of those, that may help us make our choice between those 2. Those 2 drugs both have randomized data. The data for methotrexate is conflicting in some studies. Some studies show good effect and other ones shows less of an effect. They kind of threw all the randomized studies together into a meta-analysis, and it seems like there was some benefit. And we actually think most of the studies that were done on methotrexate were underdosed. They were using doses of 15 milligrams. Most of us would use 20 to 25. So I actually still think it's a pretty good medication. As Dr. Moore brought up before, for some types of limited or localized scleroderma, such as or forms of localized scleroderma, methotrexate is kind of our treatment of choice. And then cyclophosphamide, in the lung studies that I think I talked about during the research portion, so scleroderma lung study 1 and scleroderma lung study 2, they looked at skin involvement, and it does improve on Cytoxan. Cytoxan is, kind of as the name implies, it's a toxic medication. It's a form of chemotherapy. And so that medication it's rare for us to use that first as our first line of therapy before we've tried other ones. It's not to say that we don't do it, but because it is a more toxic medication, sometimes we'll use one of the oral options first and then move on to that. That's an IV infusion. It can be given as a pill, but most of us give it as an IV infusion. It can be associated with hair loss and other things. But again, it's shown good benefit, and if I had a family member who had scleroderma, I would consider any of those three options as a viable option to help improve skin thickening. So there's a lot of other things that are kind of under investigation right now too. And so some of these have been used off-label. Some of the people in this room might have received some of those, but they're not currently they don't currently have such a great body of evidence that we can easily get them approved, or that I would consider them kind of standard of care. And so rituximab is a B-cell medication that depletes B cells. And again, we have a trial here in pulmonary hypertension associated with scleroderma, but some people have looked and reported on outcomes for skin involvement. And then there's a whole list of other medications, most of which are all, the next three are all used in rheumatoid arthritis currently. And so we were involved in a trial of tocilizumab or Actemra, which inhibits this IL-6 molecule, and again shows some initial promising results, but I believe the phase 3 trial is still ongoing. IVIG, it has been kind of popularized by folks at Johns Hopkins. So they've described not a randomized trial, but just their single center experience with that form of therapy, and they've shown some good results. So IVIG is the best way to think about it is it's like it's almost like a blood transfusion, but instead of being blood, you're getting antibodies, and that's given usually over a series of days each month. It's invasive because you have to have an IV infusion several days in a row, and then that has to get repeated because those antibodies will go away after a while. So I tend to think of that as a better bridge to therapy, because otherwise you're committing to coming in for an IV infusion, 4 days every month forever. But it's a fairly good medication and has shown some promise. And then the ones that are lower on the list, so imatinib, and then therapies against fibrosis. So we talked about pirfenidone earlier. These are our antifibrotics that are really being investigated now. And so most of those are not used off-label currently. They're being studied, and we'll know more over the next 3 to 4 years in terms of their effectiveness. A lot of us are excited about the potential for these medications, because what we're doing now is we're dampening the immune system with the thought that the immune system kind of dysregulation leads to fibrosis, but these medications will be our first attempt at using direct antifibrotic therapies for improvement in a condition that we know is typified by fibrosis. And then the last option here is stem cell transplant. So that's an aggressive regimen. Essentially, what that entails is that cyclophosphamide that we talked about before. In a stem cell transplant, you would get a very aggressive and much higher dose of cyclophosphamide, to the point that it would usually cause complete bone marrow suppression, and then they would have to reinfuse you with parts of your immune system that they harvested before the procedure itself. We've had some individuals have stem cell transplants here in town at Presbyterian St. Luke's. We've had other folks go out to Northwestern. Dr. Richard Burt is a doc that's done a lot of bone marrow transplants and autoimmune disease. But this is an aggressive form of therapy. I think for some patients it may be the right choice, but there can be, the risk with it is that it's such an aggressive form of therapy that there can be a risk of death in the first 30 days. And so the biggest study that I saw really comes out of Europe, and that showed mortality benefit over time. So in other words, getting a stem cell transplant compared to usual care led to better long-term outcomes, but your 30-day mortality was slightly higher. So this is something definitely that would need to be discussed with your treating physician to know if this is the right choice, because it has some short-term risk and potential long-term benefit that would have to be weighed against each other. And that's something that, if anyone has heard more about it, that's something that we would obviously do in conjunction with a hematologist. So cancer docs are the ones that administer that therapy. It's not run by a rheumatologist. So I want to wrap up. I think I just have 2 more slides, and then we'll have a couple minutes. 11:30 is when we're finishing, right? Okay, so then we'll have a couple minutes for questions. But I think, as you guys know too, I think this is a slide I use when I talk to trainees, but I think probably all the patients in the room here are aware of this, and that this can be a real difficult disease because the symptoms initially may not be readily apparent to everybody, right? And so Raynaud's can be present in 10 to 15% of women, and so if that's an initial symptom, usually if I was in primary care, we provide reassurance, we talk about hand warming, but it's not until kind of symptoms add up in terms of, reflux development, sores in the fingers. And that can be frustrating because a lot of patients feel pretty poorly by the time they reach us, and they're pretty frustrated because years have passed between the symptom onset. And so part of our hope in terms of today is educating patients, but part of our goal here at the university is educating trainees because rheumatologists are in short supply, and primary care docs are the folks that probably saw all of you to begin with, and so we want to improve recognition at the primary care level so that they can, folks can get in the hands of a rheumatologist a little bit early or earlier. And then a final slide. These are just some non-pharmacologic things that I recommend to patients, and so because of that, because of the involvement of skin thickening, a lot of times the sweat glands can be affected by the fibrosis, and so people can have pretty dry skin, and that dry skin can make the itching a lot worse. So we usually tell people to make sure they're putting on moisturizer, put it on as soon as you get out of the shower. You might have to put it on multiple times of the day. In terms of itching, other than the moisturizer, sometimes we'll use some of the medications that are listed here. Again, most of the time this is a problem primarily in the first 2 years or so when the inflammatory phase is really active. And so some of the medications that you'll see listed here towards the end are medications that we would also use for things like diabetic neuropathy. And that's because kind of if we can dampen the nerve response, then people won't feel that itching quite as much. Obviously, we want to plug people into support. That's a big role of the Scleroderma Foundation in terms of support groups, information. They're an invaluable resource to us as a physician. And then, what I view as my goal in terms of working with someone with scleroderma, one is I'm there to kind of educate and explain the disease because we're probably the first person who knew a decent amount about the condition, and so we want to be able to explain to the person what's going on, what's happening. And then I want to make sure that I assess whether the symptoms that are present on the outside that we can see, a lot of times Raynaud's or skin thickening, our goal is also to make sure that it's not affecting kind of your insides, right? A lot of things we talked about today are usually the biggest, at least in my experience, it's usually the biggest chief complaint of patients is their joint pain or their Raynaud's or their skin thickening. But a lot of times we're going to be kind of pestering you guys about getting PFTs or getting echoes, and that's because when you look at what can cause some folks with scleroderma to pass away early, it's involvement of their insides. And so even though a person's like, well, I'm hurting in my hands, I want to talk about that today, we want to address that, but we also want to impress upon folks the importance of getting some of these screening tests because the earlier we can intervene for those conditions, we think the better outcome over time. So I'll also assess for skin progression, usually with not each visit, but I usually do it a couple of times a year in terms of monitoring whether we're successful. We obviously want to focus on what's causing a patient pain and limitations because at the end of the day, quality of life is the biggest thing that we can hopefully help provide. We use a multidisciplinary approach. It's one advantage of being in an academic center is that we have folks like Dr. Menard Ketcher, who's in a different room in GI, who has expertise in kind of upper esophageal disease. We have folks in the pulmonary hypertension clinic like Dr. Bull. We have folks in the interstitial lung disease clinic like Dr. Lee. We have experts in rheumatology, and really we need to be able to pull on those resources so that the patient gets the care that they deserve. And then we need to, again, when we talked about the hands, we need to recognize what responds to immune suppression and what does not. So reflux and those symptoms, they don't respond to things like prednisone or methotrexate. So we need to make sure we address that problem with traditional therapy for reflux and heartburn. And we want to make sure that we don't overtreat with immune suppression. So again, if someone has hand pain that's from a blood vessel source, I can do a lot of harm by putting them on something like Humira. people can die from infections from some of our medications. And so part of my job in talking with the patient is trying to separate out those two things. Thank you guys for your time, and I guess if you guys have any questions, I'd be glad to take them. Yeah, Chuck. Vasodilators? Yeah. Yeah, it's a great question. So the question was, we're talking about calcium channel blockers, but then some people might have osteoporosis or osteopenia, and they're actually taking calcium, and are we kind of fighting against each other? So calcium channel blockers kind of block the effects of calcium at muscles, but they don't deplete your total body calcium stores. So if you're on a medication like amlodipine for Raynaud's, it won't make necessarily your bone health any worse. And if you're taking calcium on the flip side for osteoporosis, we don't think that makes Raynaud's worse either. The one question that kind of comes up too is that I think someone who has calcinosis, does taking calcium for osteoporosis make calcinosis worse? I think I would probably, in that circumstance, I would just have to monitor the overall amount of calcium. We think now in bone health that vitamin D is probably more important than even calcium. That doesn't mean there's no role for calcium, but I think, previously when I was like a trainee in 2007, we were giving everybody 500 milligrams of calcium 3 times a day, and I think we were probably overdoing it because there's some study like the Women's Health Study and the Nurses' Health Study that looked at when you take a high dose, 1,500 milligrams of calcium or above, that it can lead to deposition of calcium in the arteries and those things. So the short answer is that those are not competing interests in terms of treating Raynaud's and osteoporosis, and if you have calcinosis, you should just talk with your doc about what the appropriate amount of supplement is for you. All right. Oh, one more. Yeah.
And then I did, I've heard that the drugs that are used for GERD cause actually calcium.
The drugs used for GERD, yeah. So that can be true. So proton pump inhibitors, most reflux medications can decrease calcium absorption, and that's thought to be the mechanism of action of low bone strength. And so, I think the best thing to keep in mind, a lot of folks, let's say we weren't talking about scleroderma, acid medications are overused in the U.S. Someone gets put on them and then they stay on them for life. The issue, though, in scleroderma is that, boy, a lot of times when we've tried getting folks off of the medication, so if we treated for 3 months, reflux was better, and then we tried coming off of it, a lot of patients don't do well in terms of they have a lot of recurrence of their symptoms. So I think that we know that happens. We know it can happen, I should say, that if you take an acid blocker, it can decrease calcium absorption. So if someone's on that long term, that's just somebody that we're going to keep a close eye on their bone density status and try to, I hate to say treat a medication with another medication, but that might be an approach that we use for somebody that requires acid blocking therapy. Because there can be consequences. It's not just a symptom issue. If you have uncontrolled acid that's splashing up against your esophagus, people can develop something called Barrett's esophagus, which is a precancer. So I think we need to make sure that we're not undertreating as well. Yep. Yeah. So traditionally it's checked, there's an X-ray. So the question was, how do we check for bone density? It's usually done by kind of a specialized X-ray that can measure the density of the bones at the spine and the hip. It's controversial what to do in somebody who is still, I'm not going to guess on your age, but anybody who's certainly of childbearing age, it's somewhat controversial because some of the bone health medications, we don't know what effect that would have if you were to become pregnant. So sometimes with young women, if they say, I'm not going to have kids, and then I've actually verified that they have a way to ensure they're not going to have kids. So in other words, they're not going to become pregnant, and then they've been on this medicine for years and years. We could do a bone density scan. If you haven't had one yet, that might be the reason, is that you're young, so you're less likely to have a bone fracture anyway. And then 2, certainly during childbearing years, a lot of us try to avoid bone strengthening medications unless somebody is assured themselves that they're not going to have a child. All right, I don't want to make you guys late for anything else. Oh, okay, one more.
If somebody's diagnosed with
So the question was, in primary Raynaud's, have I seen trembling as part of it? I've not seen it. So most of the time, the symptoms of Raynaud's, whether it's primary or it's secondary, obviously can be pain and discomfort. Sometimes it can be described as like burning, because when you get decreased blood flow to the actual nerves themselves, you can get burning, kind of tingling. I've not personally seen trembling or tremor associated with it, but a lot of times the symptoms can be the same. The only thing I differentiate, again, between primary and secondary is that usually primary does not lead to kind of sores on the fingertips from loss of blood flow. So, all right, thank you guys.